Good stuff? All right, let's do a very quick review about homeostasis. I'm not going to spend too much time on this, although it's a big topic for the rest of the course. But I think you guys understand between negative and positive feedback. But let's get a little bit about this. So control of homeostasis. Your body is constantly changing. It is always changing. You have physical insults that are happening, intense heat or lack of oxygen. Right? You go into a room that has no air. How does your body going to adapt to that? You know, how does your body adapt if it's going to be very hot here, or very cold? You're going to shiver. You're going to start sweating. Your body adapts to these things. There's going to be changes in the internal environment. Whether there's a drop of glucose, you learned in endocrinology how to get that glucose back up, right? You're going to have physiological stress, demands of work in school. If you've never been having something like this, don't worry. You're in pathophysiology. I'll challenge you, okay? But yeah, that's what I'm saying. You've got all these physiological kind of stress, any kind of disruptions. You have mild and temporary. The balance is quickly restored, and then intense and prolonged. Things like severe infections or poisoning, it could lead to death, right? So the body's always changing. So we have this homeostasis. You've got this values and variables all around a certain set point. So let's use this as an example. Let's say glucose. Your set point is 100. Your glucose should be set at 100 in your bloodstream, okay? But you could have 108. You could have 94, right? That's still normal. So you have this set point, but then you've got this range of values that it can happen until it goes into something that's a little bit too obnoxious, right? Maybe you got to change things, all right? So you have this whole range of things that goes on over here. So we have the set point, right? So then we have this negative and positive feedback. So here, this is negative feedback. Your glucose is supposed to be 100. Now it's at 110. Now it's at 125. Now it's at 135. Well, negative feedback says, well, it's there. Well, we're going to actually bring it back to 100. We need to make this number from where it is to where the set point is smaller, right? Same thing over here, that if this becomes 90, 85, 70, it's going to bring it back here, right? So that's negative feedback. And that happens mostly in our body, right? That's our thermostat. Temperature is supposed to be 65 degrees in this room. It goes too high, something brings it back. So, you know, that's what this is, negative feedback. But then we also have positive feedback. Positive feedback is not something that usually is a normal thing. There is some instances it is, though. So let me show you what I mean with what it is first, and I'll give you some instances where it's normal. Here's your blood sugar. It's supposed to be 100. Now it's 120. Now it's 150. Now it's 200. It's going further and further. It keeps on going. Nothing's bringing it back. This number is getting bigger. Whether you go down to here, 90, 70, 50, it's getting further from the set point. So in most cases of positive feedback, it's a disease process going on. You see what's going on? Okay? Now, there are certain situations it is normal. Here, I'll give you one. The cervix to the uterus, its set point is closed. Okay? That's what the set point is. It's supposed to be closed. Baby's coming out. Starting to open. Away from the set point. Sends a message to the brain. The brain says, oh, a baby's coming out? Okay, no problem. I'll give you more pain. Goes right back here. Makes it wider. 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 Not that much, but wider. Okay, hope not. Don't want to scare you. All right? But yeah, it goes wider. It's going further from the set point. The baby comes out, and then it goes right back down. So that's a case where it is normal for it to happen. Otherwise, the baby will just be stuck in there, right? All right? Other times is in the menstrual cycle, which you learned about with the hormones in there. I don't want to go back into that. We may touch upon that when we get into the female reproduction. But does that make sense? That bottom line is that negative feedback normally happens in our body all the time. Positive feedback, usually a disease process going on. Okay? So we have homeostatic imbalances. We can have mild imbalances, injury or stress, all right? And it's usually reversible, okay? We can have certain things happen to the cells to adapt. You see, whenever there's a cell injury, your cells have two choices. Either they adapt or they die, right? Basically the way our life is, right? You adapt or you die, right? If it's such a hard course, either adapt to it or you fail, right? The same thing. We have severe imbalances, all right, where just your body can't adapt to it. It will usually cause death. You usually have a necrosis, or as I talked to you about before, apoptosis, right? It's pre-programmed kind of death. So, as I said before, any kind of injury or stress, your body, the cells either are going to adapt or they're going to die. So you got to talk about these adaptation and death. So let's talk about the cell injury and stress. Okay? Results of cell injury is a dysfunction of the sodium-potassium pump, right? The ATPase pump. All right, we'll talk about that in a moment. Apparently, in the other class, they forgot what the ATPase pump is called. Loss of plasma membrane integrity, it starts breaking down, and things could just come in and go out whenever they please. Okay? There's some defect to making proteins. Just not going to be able to do that. You'll have an accumulation of some things in there, whether it's water or fat inside the cell. All right? And the DNA, the ultimate thing, is starts to get damaged. You can't pass on the genes, right? Etiology, that's a fancy word for causes of. Okay? The causes of cell injury and stress. Decreased oxygen. All right? Physical, thermal, chemical agents, radiation, toxins, microbiology stuff, right? Inflammation, aging, all these different things will change things. Okay? Whenever I put these kind of flow charts on here, I don't usually do it with you guys. It's just the stuff we've been talking about. Just take like 1 or 2 minutes, and you can see step by step. Because this is how you're supposed to deal with pathophysiology. Is to, if cell injury will cause reverse to normal or cause necrosis, you need to know step by step. And we're going to talk about these step by steps in the next few slides also. So, a decrease of oxygen. This is the most common cause of cell injury. You're going to see me use these abbreviations. MCC is most common cause. It's going to pop up all over my PowerPoints. MC means most common, but this is most common cause. Okay? There's some routine ones that you're just going to see doctors and other nurses use when you get into the field. Just try and get used to using that. Why write the word oxygen when you could just write O2, right? You'll get used to doing all these kinds of things because you have to write a lot of notes. Okay? But this is the most common cause of cell injury, is a decrease of oxygen. Okay? The causes could be that there's a decrease of oxygen in the air. All right? You just move up in an altitude. There's less oxygen up there, or there's less oxygen in this room. It could be that there's some kind of deformity to the hemoglobin that carries oxygen. Right, sickle cell and hemophilia and stuff, right? Or not hemophilia, thalassemia. Respiratory or cardiovascular diseases, poison. So this is you got to be able to go into this step by step, right? You shouldn't be able to, well, let me go further, I'll show you. Ischemia. Ischemia is a decrease in blood supply. That's what ischemia means. But because it's a decrease of blood supply, that means there's going to be a decrease of oxygen getting there, which means there's going to be a decrease of nutrients and glucose getting there, which means at the other end can't be able to get rid of waste because there's no blood supply getting there. So if there's carbon dioxide at the other end, I can't take you in. So those cells over there build up with carbon dioxide. You see what's going on? Right? So my thing is I want you to do less memorization, although there is memorization. But I want you to understand the material. That if you have a decrease of blood supply to an area, don't just memorize that it's going to be dead. Why? It's because there's no oxygen, there's no nutrients going over there. So if you know that a place like bone has a great blood supply, then that's great. That means oxygen is going there. But cartilage doesn't have a good blood vessel supply. That's not ischemia. They have other ways that it gets its nutrients. But if I tear cartilage, if I break my bone, which one's going to heal faster? Why? It has more blood supply. That's what I'm saying. You've got to be able to put this stuff together. You don't have to memorize. Signs and symptoms, if you understand the facts, the foundations from A&P1 and A&P2, you could put this stuff together and guess what the signs and symptoms would be. Okay? And anoxia is just a fancy word for no oxygen there. Okay? So unintentional and intentional injuries. All right, I'm going to speed up from some of this stuff. Asphyxiation, which is like choking and no oxygen getting to the lungs in area. Drowning will cause this. Frostbite, infectious, immunologic, or inflammatory areas. Trauma, gunshots. That IVDA is IV drug abuse. Okay. MVA is motor vehicle accidents. When I do my first PowerPoint presentation, kind of go in flip-flop, you'll see what those are in there. But again, these are words that you will hear in the hospitals. If you're in the emergency room, oh, there's 2 MVAs coming in, right? So get used to some of these abbreviations. Like I said, I'm a doctor, I'm an MD, so I'm going to try and throw them in, but I will surely explain what they are, or if you're not too sure, email me, all right? But you need to use these quite often, okay? Chemicals, right? Carbon monoxide, that thing that comes out of the gas muffler, right, or the gas exhaust. And it's not the exhaust that you could smell. It's the stuff that you can't smell, that you can't see, that's odorless, and all this kind of stuff. But yeah, this is carbon monoxide will block oxygen from binding to hemoglobin. Alcohol, again, I'm using abbreviations here. Ethanol is alcohol, right? ETOH, you'll see that quite often. That means alcohol. We also have acids that are doing this and alkali, so chemicals can actually cause cell injury. Ionization, radiation, right? This is your free radical stuff, which I think you guys all did in chemistry, so I don't want to deal too much of it. But basically, it's going to break up, high-intense radiation is going to break up water into hydrogen ions, and this is a dot there because that's what it is, not a minus, not a plus, because it's a free radical, okay? What happens here is that free radicals are attracted to the cell membranes of your body, and then they attach to the cell membranes and destroy them, damages them, and allows the free radicals to go inside the cells and destroy the organelles and the DNA for that matter. We don't want that. We need to get rid of those radicals. All right? If you have an acute exposure to it, it's going to destroy the white blood cells by this manner over here. If you destroy the white blood cells and you increase more of the epithelial loss, think about it. Epithelium, your skin. You're going to destroy your skin and you're going to decrease your white blood cells. Now, that means that any bacteria that's around here, you just opened up a window to allow it to go inside your body. So if you decrease your white blood cells that are supposed to fight off infections or fight off bacteria, and you increase this, making your skin being very thin, well, you're going to have an increase in infections. Okay? Does that make sense? And you have a chronic amount of exposure to these free radicals. It causes DNA mutations. It can even cause cancer. So, of course, what Dr. Oz wants to talk about is how do you stop it? You give yourself antioxidants, right? Antioxidants are in certain foods. They're like vitamin A, vitamin E, and they will they're like little scavengers, and they look for these free radicals throughout your whole body and kind of destroy them, okay? So this is, I mean, we could go on and on talking about free radicals, especially if we go into chemistry, but I think at this level, if you understand that concept, and does everybody understand that? All right, that's enough for you to carry that on, because when you become a nurse or wherever you're going to go, that's the kind of stuff you need to talk to your friends, your family, and your patients at that kind of level. That's pretty much what you need to know about that. Okay? Now we can also have an accumulation of calcium inside the cells. That's bad too, all right? When you have cell injury, you're also going to not only destroy your the ATPase pumps, but you can also destroy some of the calcium pumps. The calcium pumps are pumps that are supposed to take the calcium that are inside your cells, and they're supposed to put them out. So an increase of intracellular calcium could also be bad. All right. When you have cell injury, not only does it destroy the ATPase pumps, as we talked about before, but it could also destroy the calcium pumps. If calcium starts building up in your Normally, if calcium starts building up inside the cell, these calcium pumps can get that calcium back out of the cells. Now, some of it will go back into the endoplasmic reticulum, or sarcoplasmic reticulum, as where it should go, but a lot of it will also escape and go back outside the cell also, in the extracellular area. But if you have cell injuries and they destroy not only your ATPase pumps, but also your calcium pumps, then the calcium is going to have a hard time escaping the cells, which means you're going to have an accumulation of calcium inside. That can be bad. What it can do is that there's enzymes that are inside the cell, things like proteases, endonucleases. What will happen is these enzymes over here should break down certain things. Calcium is actually going to make these enzymes over here speed up and destroy things much rapidly, meaning it's going to destroy your DNA, it's going to destroy your membrane, it's going to destroy things that are going to make ATP. You don't want to have an accumulation of calcium so much in the blood that you can't let it go out. You want it to go out. You don't want it to accumulate too much into the body. Otherwise, it's going to destroy things, as you can see here. Okay? So I do want you to know about that too. Just the one slide on calcium. All right, so mild cell injury. All right? It's reversible. Acutely, it'll be brief, but you'll see the visible change, and it can either be something called hydropic change or fatty change. We'll get into that. It means there's a lot more water that goes inside or a lot more fat built inside. Okay? If it's a chronic thing, then there's going to be a slew of different things that will happen. We'll talk about those, atrophy and hyperplasia and whatnot. So that's what happens over here. But again, your body is adapting to the cell injury, and this is how it has to do. So we have hydropic chain, also called vascular degeneration. And this increases intracellular water. Hydro meaning, hydropic meaning water. Okay? So, the ATPase pump. All right, before I do this, let's try it. What is the most common cation found inside the cell? You tell me your question.
Yes?
Yes.
Potassium?
Okay. What is it? Potassium, right? What is the most common cation outside the cell? All right.
Sodium?
Yeah. You memorize it, right? My salty banana. They never did this, right? Mine, mom. Okay. The salty banana. All right, let's go back to kindergarten. What is the banana loaded with? Potassium. So you're right on that. So the banana is our cell, and inside the cell, it is loaded with potassium. Outside the cell, we were putting a lot of salt on it. What is salt usually in terms of ions? Sodium and chloride, yeah. So what you're doing is you're putting a lot of sodium on the outside, and inside there's a lot of potassium. There, salty, right? Okay. Now just go. What's the most common anion? Not only is it the most common cation outside the cell is sodium, what's the most common anion or negative charged ion outside the cell? Chloride. Works perfect. The only thing you got to memorize is the most common anion that's found inside the cell. Well, that's phosphate. All right? That's the only thing you got to memorize. Otherwise, you just know the salt is an anion. Does that make sense? Not bad, right? It's fun. All right. Now, let me ask you this. Now, keep in mind that even though there's a lot more potassium inside the cell, there is potassium outside too. But there's more inside. Likewise, there's more sodium outside the cell than there is inside the cell. But there's still sodium inside too. Okay? Fair enough? Let me ask you this. If the sodium gates open on the membrane, does sodium want to go into the cell or does it want to go out of the cell? Inside, right? Simple diffusion. High concentration going to a low concentration. Depolarization if you like to use the, action potential. If the potassium gates open, does the potassium want to go out of the cell or into the cell? Out. Because there is more potassium inside than out, it's going to go from a high concentration to a low concentration. Easy, right? Okay? Does that make sense? Now, the problem is, not the problem, but we also have, if that continues, let's just talk about sodium. If sodium keeps on going inside the cell, then eventually we're going to have problems getting, well, you're going to have too much sodium inside the cell then. We've got to put the sodium back out there so that we have that gradient. So we have something called an ATPase pump, or the sodium potassium pump, same thing. And what that does is that's going to actively, with active transport, it's going to push sodium against its gradient. It's going to go from a low concentration to a high concentration. And it's going to do the opposite of potassium. It's going to put the potassium from a low concentration to a high concentration. Right? It's going against the gradient, so it needs ATP to do that. Now, how much sodium goes out? How much potassium goes out? That's also an important thing. Well, there's 3 sodium going out and 2 potassium going in. This is all old stuff. You have to have mnemonics to help you along with this kind of stuff so you could study more of the harder stuff, right? So how did I come up with a mnemonic for this one, besides the salty banana? All right, because you need to know 3 sodium out and 2 potassium in. So you know that song, na 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 na, hey hey hey, right? You know where I'm going with this, right? So in college I had issues with this, right? I was like, I had to memorize this and stuff and spend 5 minutes just to do this. Then it hit me when I was in medical school. I was listening to this song while I was studying the action potential again. And it was going, na. Now, first off, how do you spell na? See how things start rolling for me, right? And then I went, na, na, na. How many times did I say that? So far, so good. And I just said it. Na, 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 out. Na, 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 out. KK goes inside. I don't have much of a social life. All right? But making up mnemonics, when I was in medical school, I was like the mnemonic king. When I was making up mnemonics, it makes it more fun, right? I mean, think about it. Salted banana, na 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 na. You now know the whole thing about sodium, potassium, and stuff. Something that normally would take you maybe 20 minutes to figure out. Come on, right? That's what you got to try and do with this, okay? So, now, with that said, you understand now the ATPase pump. Look what's going to happen when hydrophic changes. If you have a decrease of oxygen, the ATPase pump is damaged. If you don't have oxygen, you can't make ATP. You can't make ATP. you're not going to make an ATPase pump. So therefore, is sodium going to stay inside the cell, or is it going to go out? We just destroyed the ATPase pump. So does the sodium want to stay in, or does it go out? It stays in. Does that increase the charge inside, the concentration? So if the concentration is increased inside, becomes hypertonic inside, do you understand why water has to go in to dilute it? Sodium enters the cells, the diffusion, because now sodium, it could just go in naturally. Nothing's going to put out this sodium. The sodium doesn't go back out. Water is then going to follow it to keep that concentration there. So these cells start swelling with water. That's why we call it hydropic change. Now keep in mind also that you're going to have a lot more potassium exiting the cells also because we don't have the ATPase pump working. Okay? You see, step by step. Don't friggin' just memorize. You got to go step by step. It'll make sense. Will it take a long time? Absolutely, because you haven't been taught this way. You haven't studied this way. But when you get into these other harder courses, they kind of expect you to do this. And it will, when it comes making more sense like this, trust me, it becomes more fun. You get your answers more correct, and like, oh, I like this stuff, right? And if you don't like it, you go change your major. Gaming is pretty good in school. All right. And it's reversible as long as the stimulus is removed. Okay? So, step by step, here's where all happens. And you can see over here that as the sodium comes in, water is going to follow, and these things start becoming big balloons that are filled with water. Okay? This is what normal cell hepatocytes kind of look like, but then when you start seeing hydropic changes, you can see that filling up with water. Okay? All right, fatty chains. It's also called steatosis. Okay? This is when we increase the intracellular fat. Okay? MC, most common. All right? You'll see that quite often. Most common in liver cells. It's due to, the reason is because the liver is a strong role in fat metabolism. I'm not going to go into too much detail about it. You've already learned about that in AP1 or AP2. But the most common cause, MCC, is alcohol abuse. They will cause this fatty change. Okay? We also see it in obesity, so not just alcohol abuse, you do see it in children and young adults if they're obese. But we see it a lot more with alcohol abuse. Okay? And it leads to cirrhosis and liver failure, which we'll talk about when we get into the GI tract. Okay? It's reversible as long as the stimulus is removed. Okay? So here you can see some of the fatty chains. It's filled with fat, right? Fat doesn't really stain very well. You can see right through it. They look like adipose tissue. That's what it looks like, right? And adipose is filled with fat. That's what's happening. Okay? Here's a kidney that's normal. Here's a kidney that has a fatty change. See all the yellow in there, right? You can see it grossly too. Other things that could accumulate inside this cell besides water and fat, we could also have cholesterol leading to atherosclerosis when it starts building up the walls of these blood vessels. Okay, proteins, pigments, environmental particles, and so forth could also build up in here. Okay. Okay, so abnormal cell growth. All right, atrophy. Still, we're talking about injury, mild injury. All right, so if it doesn't go through hydropic changes or fatty change, it could do this also. Atrophy, it could decrease in cell number and size. And I'll show you pictures of this too. Hypertrophy, cells could get bigger. not by number, in size. A good example of this is muscles. All right, when people are lifting up weights. Now, this is an increase in cell size not because water is going in there and the cytoplasm is getting more. It's because there's more proteins that are usually being accumulated in there. So when you're lifting up weights, you're building more myofilaments. You're building more actin and myosin, which are proteins. That's making the cells get bigger. It's not that there's more water going in there. So that's what's happening with that, hypertrophy. We have hyperplasia, and this is increasing in cell number, not size. You make more cells. Then we have something called metaplasia. Now, metaplasia, it's not a hard thing to understand, but it's an important thing to understand. Metaplasia is basically an area of the body that has chronic irritation to it, and your body is, that those cells are adapted. Let me give you an example. The endothelial cells of the trachea are normally what? Good try. Yeah. Give it anything. Yeah. Yeah. Say something. Wrong. Okay. But I know the next thing was going to be pseudostratified epithelium. Exactly. All right. See? Okay. So yes, normally in the trachea is pseudostratified epithelium, which is one layer. Different sizes. It looks like a lot of layers, but it's only one layer. Now this is what happens. Someone's smoking. The smoke irritates the lining of the trachea. That smoke is then going to seep through that one layer and go to deeper tissues and damage that tissue. Not good. So your body has to adapt to this chronic irritation. So the cells, the pseudostratified cells will change. They'll adapt, and they'll change into an epithelium that is made for protection. They'll become many layers. What is that called? Starts with S, ends with stratified. Stratified, good. And the first part, it starts with S, Q. Yeah, there you go. Go ahead and go further. So what happens here is a pseudostratified epithelium, which is one layer, is getting bombarded with this smoke, and it gets smart and says, we're going to change into something that has a lot of layers. We're going to change into squamous, stratified squamous epithelium, which is on your skin, protection. On the esophagus, protection. So what's happening on metaplasia is that under chronic irritation, the tissue becomes something totally different, but recognizable. It's just in the wrong place. Stratified squamous epithelium should not be in the trachea. So if someone throws you a bone and says, hey, not a bone, but let's say throws you a trachea slide, microscope slide, and says, that's trachea, and you see stratified squamous epithelium there, you don't have to tell me anything more. What's irritating this trachea, Dr. Gamaro? How'd you know that? Well, it's normally supposed to be pseudostratified epithelium, but you're telling me it's a trachea and there's stratified squamous epithelium. That's not normal. That's saying that there's metaplasia there. Very good, eh? See, it changes. And then when the smoking disappears, then it'll revert back. It doesn't do it instantaneously. We're talking about weeks to months. Okay?
Let us look at the cellular adaptation metaplasia. We shall start with normal cells. If these normal cells are subjected to persistent irritation or low-level injury, the tissue may replace them with another type of normal cell that is better able to withstand the injury. Metaplasia is the replacement of a normal type of cell with another normal type of cell. The new cells are normal, but they are a different kind of cell. The previous cells themselves do not change into different types. As these cells die, the progenitor cells in the tissue differentiate into the new type of cell, which replaces the previous ones. Metaplasia enables a tissue to survive in a harsh environment. Let's see an example of metaplasia. You are now looking at the normal ciliated epithelial lining of the bronchi. Note the cilia on the columnar cells. See how the cilia move the mucus upward? What will happen if this person smokes cigarettes repeatedly over a long period of time? Chronic exposure to cigarette smoke causes a persistent irritation that triggers squamous metaplasia. As the normal ciliated columnar epithelial cells die, they are replaced by stratified squamous epithelial cells. The stratified squamous epithelial cells do not have cilia, but they can survive in the harsh environment created by cigarette smoke. Metaplasia is potentially reversible if the person stops smoking. If the person does not stop smoking, the same irritant stimuli that caused metaplasia eventually may trigger malignant transformation in some of these cells.
So does that make sense what goes on here? It's metaplasia because of an adaptive thing, as opposed to dysplasia. Dysplasia, for some reason, these are cells that change into something we cannot recognize. They turn into stars. Doesn't make sense. Now, sometimes this can happen because of chronic irritation, but not all the time. And the problem is that this turns into things that we can't recognize. These can actually become cancerous. So we got to be careful with dysplasia. And the one that we're really being concerned about is cervical dysplasia. This is the reason why you do pap smears. Okay? Cervical, you see it there. I need to know a little bit more about this patient. I like to know, okay, you have cervical dysplasia. Is there any vaginal cultures that you did? Because I need to know. Oh yeah, she also has gonorrhea. That may be the reason why dysplasia. So what I want you, if you have something dysplasia on a pap smear, you don't let them, you don't wait a year to settle this. You got to say, okay, she gets treated for the gonorrhea. I want her back in 4 months. I want to redo the pap smear. Comes back normal, fine, we found out the reason. Comes back still dysplasia, well, something else is going on here. Now we got to take biopsies and go further and stuff.
Dysplasia may be viewed as an attempt at adaptation that has gone astray. Dysplastic cells have abnormal variations in their size and shape, and they may precede the development of cancer in an area of chronic irritation. Dysplasia most frequently occurs in a squamous epithelium. Here is a normal squamous epithelium in a cervix. The cells move upward from the basal layer as they mature normally. Note the normal squamous cells on the top surface and the orderly progression of cell maturation. Dysplasia may arise with repeated irritation from infection. This is cervical dysplasia. It is also called CIN2, cervical intraepithelial neoplasm, grade 2. Note the disordered progression of cell maturation. A severe dysplasia may progress to cancer.
All right. Does that make sense? All right, what dysplasia is all about? Okay. So this is just a picture showing them all. All right, here's normal cells. Here's atrophy, and the cells got less in number and less in size. Here's hyperplasia, with a just increase in number. Here's hypertrophy, with an increase in size. This is metaplasia, where these are your normal cells, and they turn into a different cell that we can recognize. It's just in the wrong place, on top of the base of the membrane, right? This is dysplasia. They turn into cells we can't even recognize. Not good. What we're concerned about is that if they break that base of membrane, you got friggin' cancer. Not good. We want to stop it here. We get it here, then go chemotherapy, surgery, other things. We need to stop it before it gets there. That's why pap smears are very important. Okay? Fair enough? That's my little OBGYN pitch. Okay?